Let's Talk Parkinson's series. Parkinson's Community Los Angeles, or PCLA, is a nonprofit with the goal to connect individuals, families, to the information, support programs, and activities they need to enhance wellness and live an active, engaged life. So before we dive right in with Dr. Keener, let's review a few rules of the webinar. Please make sure your microphone is muted. This eliminates any background noise to ensure we can hear our guest speaker clearly. If possible, use the chat function within Zoom to type and submit your question. I will read it out loud for all to hear. And since typing may be difficult for some, I will ask for verbal questions from the audience. Please wait until I ask if there are any verbal questions. If you have one, please unmute your microphone, say your first name clearly, and ask your question. And please keep your question on topic, especially during Q&A. We'll try to answer other questions if there's time at the end. And please feel free to start submitting your questions now through the chat. That way I can start collecting them for when we're done with Dr. Keener's presentation. Without further ado, I'd like to introduce Dr. Adrienne Keener, who will be discussing Parkinson's medications and of course answering all of your questions. Dr. Keener is a board-certified neurologist and movement disorder specialist at UCLA and the West Los Angeles VA Parkinson's Disease Research Education and Chief Clinical Center. She's also a member of the American Academy of Neurology, the American Neurological Association, and the International Parkinson's and Movement Society's Disorder. It is my pleasure to welcome Dr. Keener.
Thank you so much for having me. So I will pull up my presentation here and we'll get started. All right. So I thought I would begin today by giving a brief overview of the common symptoms in Parkinson's disease, demographics, and sort of the underlying pathophysiology or cause, because that will really set us up for diving into the different medical treatments for Parkinson's. Throughout this talk, I'd just like to emphasize that for any individual person with Parkinson's, the symptoms can be unique to that individual, and therefore the treatment plan also is tailored to that individual. So really communicating well with your treatment team, physicians, therapists, etc., to develop your own personalized treatment plan is the goal. All right, so of course we most commonly recognize Parkinson's disease by its motor symptoms. And these include stiffness, slowness, and tremor, most commonly. The stiffness we sometimes refer to as rigidity or cogwheel rigidity. The slowness we refer to as bradykinesia. And tremor can be very prominent in patients with tremor-dominant Parkinson's disease. But in up to 20% of people with Parkinson's, the tremor can be absent. Other motor symptoms include dyskinesias, and these are the involuntary extra movements that may develop later in the course of the disease as a side effect of therapy. Dystonia is a specific term we use to refer to painful muscle cramping. Very commonly, this affects patients with Parkinson's disease and manifests as their toes curling under, for example. Walking problems or walking changes is also another motor symptom. This can include shuffling, not picking your feet up as well while you're walking, or even freezing of gait, which is where your walking comes to a halt and you have difficulty initiating a step. Balance difficulties can develop later in the course of the disease and lead to falls, which of course we want to prevent as much as possible. In addition to these motor symptoms, however, there are also a lot of non-motor symptoms of the disease, and this is sometimes referred to as the tip of the iceberg phenomenon in Parkinson's, where what's above the water are the motor symptoms, those symptoms that we can see, but below the water can be a host of other symptoms that are not readily visible. This can include changes in mood, like depression or anxiety, changes in your sense of smell. Pain is very common, and this can be because of the underlying stiffness, but also other types of pain can occur in Parkinson's. Constipation is also very common and often precedes the onset of movement symptoms in Parkinson's. Urinary changes and even incontinence can develop later on. Low blood pressure can also be part of the autonomic nervous system changes in Parkinson's itself, and can also be a side effect of some medications, as we'll discuss. Sleep disruption is also very common in Parkinson's disease, and there's a somewhat unique sleep disorder called REM sleep behavior disorder, where you act out your dreams at night. That's very highly associated with Parkinson's disease. Much later in the course of the disease, thinking problems can arise as well. So what do we know about Parkinson's? What causes all of these symptoms? Well, we know that after Alzheimer's disease, it's the second most common neurodegenerative disease. It's estimated to affect 1 to 2% of the entire population over age 65. Several studies have shown that it affects men more often than women in about a 2-to-1 ratio. And the average age of onset of Parkinson's disease is about age 60. When patients have onset of their disease under age 50, we sometimes refer to that as young onset Parkinson's disease. And very, very rarely, children can have Parkinson's disease. We call that juvenile onset Parkinson's disease. So underneath all of these symptoms, we see characteristic changes in part of the brain called the basal ganglia. And this is really a circuit comprised of several structures deep in the brain that help control our movement. Under the microscope, which is a picture here, we see within some of these cells in part of the brain called the substantia nigra, these pink little blobs, which aren't normally there. And those are what we call Lewy bodies. And those Lewy bodies are comprised of an abnormal aggregation of protein called alpha-synuclein. When we look at an autopsy, we see this black substance here, the substantia nigra, named black substance, because it appears somewhat dark because these cells contain melanin. In a patient with Parkinson's disease, we can say that those cells have faded away and it's not quite as dark as it should be. So there's these blobs, these Lewy bodies in these cells, and that's causing a loss of function of these cells which produce dopamine. So when we are approaching treatment in Parkinson's disease, many of our treatments are geared at replacing or enhancing that dopamine that we know is deficient in Parkinson's disease. The goals of our treatment are to reduce the severity of symptoms, improve your daily functioning, and your overall quality of life. We don't yet have a treatment that will slow down disease progression or stop it for that matter, though those several treatments are in development aiming to achieve that goal. So first of all, I want to start with non-pharmacologic treatments in Parkinson's disease. So there are a lot of things that you can do before even thinking about a medication that will improve your quality of life and your symptoms with Parkinson's disease. Exercise is the first and foremost, and I'm going to spend a separate slide discussing that. Nutrition is also very important. So there's some evidence that certain dietary factors may increase a person's risk of Parkinson's disease. For example, high dairy intake. And there's some evidence that a Mediterranean style diet or a diet high in antioxidants is good for overall brain health. Because patients with Parkinson's often struggle with constipation or low blood pressure, we know that staying well hydrated, drinking plenty of fluids is important, and eating a high fiber diet can also help. And finally, part of the reason you are all here as part of PCLA is the role of education and support in managing Parkinson's disease. So the more you can find a community who can teach each other and support each other through Parkinson's disease, that has been shown to be very beneficial in the long run in helping you really manage your symptoms and your disease. When it is time to start medications is often a question we get. When should I start a medication? And all of the treatments we have currently are symptomatic, meaning they will address the symptoms of the disease, but won't necessarily change the long-term course of the disease or the rate of progression of disease. So really, we start treatment, pharmacologic treatment, when symptoms are functionally impairing, when they're holding you back from doing something you want to do and affecting your quality of life. And finally, as I mentioned earlier, we really want to individualize our treatment plan to your specific symptoms and their severity. We also want to take into consideration your age, other medical problems you might have, and also the cost of medications, because some of the newer medications in particular can be quite expensive and cost prohibitive for certain patients. So a brief timeout to talk about exercise in more detail. So there have been many studies looking at the benefits of exercise in Parkinson's disease, which are wide-ranging. It can improve your muscle strength, flexibility, your joint range of motion. We also know that while our medications can help with stiffness and slowness and tremor to some extent, walking and balance issues are not as responsive to medications, and physical therapy and exercise are actually our best treatment to impair those symptoms. We also have very strong evidence, both from animal models of Parkinson's disease and in people with Parkinson's disease, that exercise may actually be neuroprotective, may help slow down the progression of disease over time by stimulating certain growth factors in the brain to keep those brain cells healthier longer. And so I mentioned earlier, we don't yet have a prescription that I can give you to slow down your disease progression, but exercise is actually probably the most important medicine you can do along those lines. We also know that exercise can help with non-movement related symptoms in Parkinson's disease, including sleep, energy levels, mood, and concentration. There's no specific exercise plan that's necessarily best for Parkinson's disease. Those several different types of exercise have been studied and have different benefits. Yoga, Tai Chi, cycling, through our collaborations with physical, occupational, and speech therapists, specific programs have been designed for patients with Parkinson's disease. For example, big and loud therapies are one of those examples. And so we often say exercise is medicine in Parkinson's disease, and it's for these reasons that exercise is always a part of the treatment plan in Parkinson's. Moving on to the medications, we'll just review the most common medications and the way they work and some of their common side effects. So levodopa is our gold standard medication for treating the motor symptoms of Parkinson's disease. It's a medication that basically gets converted directly into dopamine when it enters the brain. It's always given in combination with another drug called carbidopa, which basically blocks that change from levodopa to dopamine in the periphery, in your stomach. And so that way the levodopa gets intact into the brain where it can then be converted to dopamine and have its effect. This medication is known by many other names. Sinemet is the old brand name, the most common name it's referred to. It also comes in a CR or controlled release formulation. Rytary is the newest formulation of carbidopa levodopa orally. It's a mix of short and long-acting beads of medication within a capsule that's designed to have a smoother onset and offset of action. Duopa is actually a gel form of the medication that's delivered through an infusion in a tube that's surgically inserted into your small intestine. And then most recently on the market, we have Inbrija, which is a levodopa inhaler, which can be given for a rescue during sudden or severe wearing off periods. And so levodopa can take many forms, but does remain our most effective medication and our gold standard for the treatment of motor symptoms in Parkinson's disease. Now, the oral forms of levodopa have to be taken at least 3 times a day. So we have yet to come up with an oral form of this medication that can last 24 hours. That's truly long acting. So that sometimes can be a barrier, a deterrent when somebody's first starting a medication to have to take something multiple times a day. Sometimes the controlled release form can be given at night to help with overnight wearing off symptoms. And the most common side effects of levodopa are nausea, orthostatic hypotension, which refers to lightheadedness upon standing from a drop in your blood pressure. And at higher doses, or in more sensitive patients, hallucinations can also occur as a side effect. In development right now, I will just mention they are working on a transdermal or patch form of levodopa. So we'll see how that goes. The other most common medication that people start with as initial therapy in Parkinson's disease are the dopamine agonists. And there are several in this category listed here. Pramipexole and ropinirole are both tablets that come in 3 times a day or once a day long-acting version. Retigotine comes in a patch known as the Nucro patch, so that's a once-a-day patch. And then finally, apomorphine actually comes in several forms. The most recent was just FDA approved earlier this month. It's going under the brand name Kinmobi, and it's a sublingual form to be used as a rescue medication. There's also an ongoing clinical trial currently looking at a subcutaneous pump of this medication. So dopamine agonists, while they can be effective at addressing motor symptoms, tend to have more side effects than levodopa. So in addition to the nausea, hallucinations, and lightheadedness that levodopa can sometimes cause, these medications can also cause swelling in the legs, known as edema, and extreme drowsiness, even leading to what we call sleep attacks, where you fall asleep very suddenly without warning. And most importantly, these medications, this class of medication, causes a very unique side effect that we call impulse control disorders. These are characterized by impulsive or compulsive behaviors that are out of your control, sort of out of your character. Oftentimes, these are sort of pleasurable behaviors that then take on a life of their own. Common examples include gambling, excessive shopping or spending on something, hypersexuality, and binge eating or overeating. As with many medications, the goal to avoiding side effects with this class of medications is start at the lowest dose possible and increase it very slowly over time so you can monitor for any side effects that may develop. As I mentioned earlier, one of the benefits of this class of medication is that it comes in an extended release once daily formulation. There are also medications that we can sometimes add on to enhance the effects of levodopa in particular, and the COMT inhibitors are one class of those medications. So entacapone or Comtan is the most common form of this. It's a pill that's taken with each dose of your carbidopa levodopa, and actually comes in a combination pill commonly known as Stalevo. And it blocks an enzyme here in the pathway that breaks down dopamine. So when dopamine gets released from the cell, it goes through a natural metabolism to get sort of recycled and reuptake. And so this medication blocks that step so the dopamine hangs around in your brain a bit longer. This medication most commonly can cause diarrhea and nausea as a side effect. The diarrhea occurs in less than 10% of people, but can be very severe. And this medication also, it's sort of a tan colored tablet, and it will discolor your urine. This is not dangerous, but I've found that if you don't warn patients about this, then they start taking it and their urine turns this bright yellow or orange color, and they get concerned. But it's not dangerous, it's just from metabolizing the tablet. Just recently, earlier this year, in fact, a once-a-day version of a COMT inhibitor called opicapone, going under the brand name Ongentys, was FDA approved. And so that'll be a once-a-day form of this medication that you can take. Another medication that can be used either alone as what we call monotherapy by itself when symptoms are very mild, or as an add-on to your other regimen to enhance the effects of levodopa are the MAOB inhibitors, and we have 3 of those, selegiline, rasagiline, and safinamide. I put the brand names alongside here as well. These medications block another enzyme in the step of dopamine breakdown. So again, keeping the dopamine that you have lasting longer. It has a pretty small symptomatic benefit as monotherapy. So in early symptoms, this medication can have a mild benefit for mild symptoms. Side effects are quite rare. In older patients who might be more sensitive to medications, we rarely see confusion or hallucinations as a side effect. Another important thing to note about this class of medications is that they can potentially interact with other medications you might be on, including certain painkillers and antidepressants. And so it's important that your physicians know all of the medicines you're taking, not just the ones for Parkinson's, so that they can be aware of any medication interactions. Selegiline, I'll also just mention here, is the oldest medicine in this class and is rarely used anymore. But it does have sort of a unique amphetamine-like metabolite, so people can feel a little bit jittery, almost if they've had like too much caffeine on selegiline at times. So that's a unique side effect of that one. One other new medication that was just FDA approved in the last year is a medication called istradefylline, going under the brand name Norians. And this medication was exciting because it's really a novel mechanism of action. So this medication blocks a receptor in the brain called the adenosine receptor. And this receptor is found throughout the basal ganglia. And this can modulate dopamine activity. So by blocking this receptor, we can enhance the dopamine release and activity within the basal ganglia. This medication was FDA approved as an add-on medication to levodopa to address wearing off. The most common side effect really seen in the trials was that it can exacerbate dyskinesia. So if you're already experiencing some of those involuntary extra movements, this medication can enhance those a bit. It's a once-a-day dosing, so that's convenient. Other potential side effects include insomnia, dizziness, and hallucinations. There are a couple of other classes of medications that we use in treating specific symptoms in Parkinson's disease. The first are the anticholinergics, like trihexyphenidyl, for example. These can be particularly good in patients who have very severe tremor or dystonia, but they unfortunately have a lot of side effects, more so than our other medications. These include dry mouth, constipation, hallucinations, confusion, or memory impairment. And again, the older you are, the more sensitive you might be to these side effects. Amantadine is another unique medication that works actually in several different ways in the brain, not just through dopamine, but through some other chemicals in the brain as well. And it has a very mild benefit early in Parkinson's disease. Was actually discovered because it was originally developed to treat the flu. And they observed that patients who had Parkinson's who were taking this medication for their flu symptoms actually had improvement in their Parkinson's symptoms. But really where its use is quite unique is as an adjunct to levodopa to decrease those dyskinesias, those involuntary extra movements that can develop. This medication rarely can cause a unique rash, which is called livedo reticularis, so that's important to look out for. And again, it can sometimes cause confusion or hallucinations. More recently, just in the last 2 to 3 years, we have extended release once-a-day versions of amantadine, 2 different ones known as Gocovri and Osmolex. You can't use this medication, however, if you have kidney disease, since it's metabolized and excreted through your kidneys. So we also have treatments geared at specific non-motor symptoms of Parkinson's disease. So I mentioned to you that these are often those symptoms that are under the surface in that iceberg analogy. But these symptoms can have a significant impact on quality of life, especially as the disease progresses and these symptoms become more common. So I'm not going to go through all of these in great detail, but we address each of these symptoms individually and symptomatically. So again, we don't have any prescription medications that can prevent any of these symptoms, but we do have several medications that can help manage these symptoms. So whether it's cognitive decline, hallucinations, changes in mood, changes in the autonomic nervous system, such as constipation, urinary urgency, that orthostatic hypotension or lightheadedness, drooling, which is also quite common in Parkinson's, or sleep issues. And I'll just mention here that, you know, sleep hygiene is always important in managing sleep issues. So making sure you set a regular bedtime and wake up schedule, making sure that you're exercising every day, that can improve your sleep quality at night. Of course, avoiding caffeine later in the day, avoiding eating too close to bedtime. And as much as I know it's hard to do, trying to avoid screen time before bed. So whether it's your cell phone, a tablet, or TV, that blue light that we get from screens can really activate us. And so developing a good wind down routine before bed can really help set the stage for better sleep. It's also important to evaluate and treat, if it's found, sleep apnea, which is very common. Not directly associated with Parkinson's disease, but can exacerbate other sleep issues in Parkinson's disease. And finally, for that acting out of dreams in sleep, we have some specific medications, melatonin being an over-the-counter supplement that's very safe, which is the first-line treatment for that problem. So I'm happy to come back to answer questions about treating any of these symptoms in the Q&A period. Now, as Parkinson's disease progresses, that duration of benefit you get from a dose of your medicine tends to shorten. So we, as we advance through the different stages of Parkinson's disease, whereas in the beginning our levodopa might last 6 to 8 hours, that time interval becomes shorter over time, and also the therapeutic window narrows such that we develop what's called motor fluctuations, where after a dose of medication, we may develop dyskinesias when the medication is reaching its peak, those involuntary extra movements. And then as the medication wears off, we may develop what we call wearing off, with the return of troublesome motor symptoms of the disease. So we have some strategies to address this. And really the goal is to change the dopamine in your system from a very pulsatile, roller coaster up and down delivery to sort of a smoother delivery of the medication to try to help smooth out those motor fluctuations. So if you're having a lot of wearing off, you might need to take your medications a bit closer together or increase the dose. You might need to add on one of those other medications we talked about. If you're having a lot of dyskinesias at the peak of your medicine, we might want to add amantadine to help control those, or you might want to lower the individual dose and therefore lower the peak of the medication and take it more frequently. If tremor is a very bothersome symptom, so tremor is one of those symptoms where if you have very prominent tremor, our medications are not great at calming tremor sometimes. So we say that, tremor can be a very troublesome symptom in Parkinson's disease because sometimes it's refractory to medications. Tremor very commonly will respond to your emotional level. So if you're very anxious or stressed or even excited, tremor will increase with that adrenaline that comes with that emotional change. And so recognizing that and using some behavioral strategies to help manage that can be helpful. So this might include relaxation techniques, meditation, mindfulness, even self-hypnosis or acupuncture to try to calm that response, that adrenaline response that can really activate tremor. I will say, however, that clinical trials specifically for these treatments have not found a clear support for their effectiveness. Occupational therapists can also be very helpful in helping to manage tremor. Adaptive devices, including specialized pens, weighted utensils, plate guards, can really help make day-to-day activities like writing, eating, and drinking much easier when tremor is severe. Some people note that a lot of caffeine exacerbates the tremor because it really gives you that surge of adrenaline. And so sometimes avoiding or minimizing caffeine can help calm a tremor. But there are no vitamins or supplements proven to improve tremor. I want to just make a quick note here also, if you're ever hospitalized or undergoing a surgery with your Parkinson's disease, there are a few important things to let your doctors know when you're in the hospital. So anyone who takes Parkinson's disease medications knows that it's really important to get those medications and get them on schedule. So we talked about those motor fluctuations and wearing off, and you can imagine if you're not getting your medicines on time and the length between doses is longer, you might have more trouble with that. We also want to be alert for swallowing problems. Sometimes in the hospital or after a surgery, you might be a bit sedated, and so swallowing can be impaired, and we hate to see people with Parkinson's aspirate where food or liquid goes down the wrong pipe into their lungs, creating another problem like pneumonia. We also know it's important to get patients with Parkinson's moving as soon as it's medically safe to do so. So getting physical therapy involved while you're in the hospital is really important. And then there are certain medications to avoid when you're hospitalized. And it's important that your doctors know about that. So medications that basically block dopamine and can really exacerbate your Parkinson's symptoms. So these include haloperidol and metoclopramide most commonly. Haloperidol is a medication sometimes used for agitation or confusion that can develop in the hospital. And metoclopramide is a medication sometimes given for nausea. So there are safe alternatives to these medications, but it's important to avoid these ones specifically. And then if you have a deep brain stimulator, there are also special precautions to be aware of if you're undergoing surgery or if you need an MRI scan that need to be followed. So I'm just going to very briefly touch on when to think about deep brain stimulation surgery or surgical treatment for Parkinson's disease. And then I'll leave plenty of time for questions here at the end. So in a patient with Parkinson's disease, when do we think about surgery? So candidates for surgery have a definitive diagnosis of Parkinson's disease, usually have had Parkinson's for at least 5 years. That's in part to ensure that the diagnosis is accurate, and also because that's usually the minimum amount of time when people start to develop the types of complications where DBS can be effective. And those indications are difficult to control motor fluctuations and dyskinesias. So if you're riding that roller coaster up and down with your medications throughout the day, and no matter how much we try to adjust them or add on other treatments to calm those symptoms, we have a difficult time controlling those ups and downs. Or if you have a refractory tremor in a patient with tremor-dominant Parkinson's disease. So you've tried many medications and none of them are really helping your tremor, and your tremor is really impairing your quality of life. So those are the two reasons that we would consider deep brain stimulation. A good response to levodopa, however, is our best predictor of a good response to deep brain stimulation. And we often say that the symptoms that get better with levodopa are those that will get better with DBS. So if you take your levodopa and it improves certain symptoms but not others, we would expect those same symptoms to respond to DBS. So what DBS can really do is help give you more time during the day in that best medication on state. So of course, as you can see, the main indications for DBS are really the motor symptoms of the disease. And so when motor symptoms are really the main cause of disability, is when DBS is helpful. When non-motor symptoms are a big part of the problem, DBS does not help with those, and in some cases can exacerbate underlying cognitive impairment or significant mood issues like depression or anxiety. And so it's important to understand sort of all of your symptoms of Parkinson's, both movement and non-movement symptoms, and how they're contributing to your quality of life. I will say that the most recent consensus criteria about indications for DBS, which was held in 2011, did not establish, firm exclusion criteria. So people often ask, is there an age cutoff? No, there's no absolute age cutoff for DBS. It really is taking into account sort of your individual symptoms, your other medical issues and surgical risks to make a decision with your treatment team. So again, as I said, the goal of DBS is to increase the best time in the on-medication state without those troublesome dyskinesias, and our response to levodopa therefore can predict our response to DBS. It does not alter the disease progression over time. It does not eliminate the need for medications, though you may be able to reduce your dose of medicines. And it does not help with those non-motor symptoms and can in fact exacerbate some of them. And finally, having a good support system around you is important if you're considering going through brain surgery like this. We have two targets, two places in the brain where we can implant these electrodes in deep brain stimulation. One is the subthalamic nucleus and the other is the globus pallidus internus. These are two different parts of the basal ganglia circuit in Parkinson's disease, and these two targets are equally effective for the movement symptoms and have other pros and cons that we would take into consideration depending on your specific symptoms and your specific situation. DBS has been around since 2002 for Parkinson's disease, so we have nearly 2 decades of experience with this treatment. And for the right patient, it can be very effective at helping with the motor symptoms. I'll just conclude here by saying that there's a lot of ongoing research in Parkinson's disease, more research trying to understand the underlying causes, looking at genetic factors and environmental factors, research looking at the mechanisms in the brain, so further understanding the electrophysiology, using functional neuroimaging to understand changes in the brain, and of course, looking under the microscope to better understand what's happening in the brain of patients with Parkinson's disease. And there's also a lot of work to develop new medications. So over the last few years, I mentioned several that have been FDA approved to help address symptoms. There have also been new surgical techniques and devices developed during this time to improve the efficacy of our surgical treatments for Parkinson's. And of course, a large part of the research in Parkinson's disease is really trying to look for those treatments that will help slow down the progression of disease, what we call neuroprotective strategies in Parkinson's. So many reasons for hope and many reasons to suspect that a year from now, the same presentation might have some new things in it. I'll address here preemptively maybe a couple of common questions that we get. So stem cells, people often ask about the potential role of stem cell treatment in Parkinson's disease. And there was just recently a one patient study published where they actually were able to derive from the patient's skin cells, turn those into stem cells and then turn those stem cells into dopamine producing cells and insert those cells surgically into the brain of that patient. And so our knowledge of sort of what stem cells are, how to create them and coax them into being different cell types has improved dramatically over time. But earlier trials have run into a few challenges in Parkinson's disease. And that includes mostly what happens once those cells are implanted in a person's brain. So keeping those cells healthy once implanted has been a challenge. And also getting those cells to integrate appropriately into the normal brain function has also been a challenge. So in early stem cell trials in Parkinson's, for example, we found that as patients who participated in those trials passed away and we looked at their brains under the microscope, those stem cells ended up having those same Lewy bodies, that alpha-synuclein inside them. And so how do we protect those cells once we implant them is a big challenge. And some of those patients also developed what were termed runaway dyskinesias because those cells began producing dopamine at an uncontrolled rate. And so how, again, do we get those cells to integrate appropriately into the normal brain function without sort of going rogue is another challenge in stem cell treatment. So this research really still is in its infancy, but we are getting closer and closer to finding answers to these questions. The last common question that I wanted to address that we often get is questions about the role of medical marijuana treatment in Parkinson's disease. So first, I'll of course state that it's not an FDA approved treatment. It is legal in 29 states, including California and in Washington, DC. Marijuana itself contains over 100 cannabinoids. The most common that you hear about are THC, which is the cannabinoid that's responsible for that high feeling people can get from marijuana. And the second is CBD, cannabidiol. And this is the one that is thought to possibly be beneficial for medical purposes. In fact, Epidiolex was a CBD-derived medication that was FDA approved recently for refractory childhood seizures. Our bodies themselves actually make natural cannabinoids, and so we have these receptors in our brain, and we have chemicals very similar that we produce on our own naturally. Studies in Parkinson's specifically, however, have been a bit conflicting. So some studies have shown, yes, this treatment can help with certain symptoms like tremor or dyskinesias. And then other studies have shown conflicting results where no, it didn't really help any more than a placebo. Part of the challenge with medical marijuana is that there are several barriers to really studying it well. First of all, it's still a federally controlled substance, and so it's very difficult to actually get permission to study this, to conduct a good trial because of the federal regulations on the drug. When we look at anecdotal reports, we have a hard time interpreting those because there can be such variability in the dose and concentration of what people are actually getting when they buy something in a medical marijuana shop. In fact, they've done tests where they buy what should be the exact same thing from two different places, and they test it and find that what's actually in it is very different. And so that makes it very hard for us to interpret the reports because we don't know exactly what people are taking. And finally, we have very limited information on medication interactions with medical marijuana. So it's just something that I think, even though it's been around for centuries and used for its medicinal purposes in cultures, even before ours, we still just have not studied it well enough to know exactly what it's doing, specifically in Parkinson's disease. I'll leave you here with a few websites where you can find some great information about clinical trials, some Parkinson specific websites, which I'm sure you've found already, and then also our website for the UCLA Movement Disorders and Deep Brain Stimulation Program. But I'm happy to answer any questions. I think Laura was collating all the chat.
I am.
So let's go ahead and get started on the Q&A portion.
Great. Thank you so much for the wonderful presentation. Super helpful. I know we have a lot of great questions in the chat. We've also received some from email and our social channels. So I'm going to go ahead and start with one that we received via email. Actually, two that had the same type of question that has to do with delaying taking medications.
Yeah.
So what are the benefits and drawbacks of delaying medication with Parkinson's? Will delaying the use of medications have a long-term detrimental effect?
So the short answer is no. So there's no real danger in delaying medication treatment in Parkinson's disease. The real key, though, is that we want to keep you exercising and active and having a good quality of life. So if your symptoms are progressing to the point that they're holding you back from participating in your exercise routine, or if they're really impacting your quality of life, then we want to treat that so that you can really maximize your ability to exercise and enjoy your life with Parkinson's. But there's no negative to holding off on medications.
Excellent. And so we do have a lot of questions about a variety of medications. Some of them you did cover during your presentation. For example, you did talk about Mirapex and Azilect. Oh, sorry, apologies. And you talked about them separately and their side effects, but we did have a question that is the combination of those two a better course of treatment than levodopa? And are there any drawbacks to starting a treatment with Mirapex and Azilect instead of levodopa?
So no. So it's very common, first of all, that a patient with Parkinson's disease is on a combination of these therapies. Over time, you might be on, one medication at first, and then a second might be added. So as the disease progresses, most people end up on sort of a cocktail of therapy using these different strategies from these different medications to manage their symptoms. So a combination of Mirapex and Azilect is not uncommon and can be very helpful. Now, whether or not it's better or worse than levodopa really depends on your specific symptoms and your specific circumstances. I would say the decision about starting levodopa or another medication at the beginning of symptoms really depends on sort of your symptoms and also the side effect profile of medications. So one is not better than another in the long run, but it really just sort of depends on, you know, how you're tolerating the medications, if you're developing side effects, you know, so they each have their pros and cons from that respect.
And in that regards, in mentioning levodopa, we have a question from Benny on our chat. Is slow release levodopa recommended over standard levodopa?
So again, that depends on the circumstances and the symptoms you're treating. So usually as Parkinson's disease progresses, people can become more sensitive to the onset and offset of their levodopa. And in that case, the immediate release levodopa is actually more reliable in terms of its absorption than the controlled release levodopa. Early in disease, however, the controlled release levodopa might be fine. You might not be as sensitive to that slower onset of the medication's action. And then, as I mentioned earlier, in particular, I often, for example, like to use the controlled release levodopa for overnight symptoms. So you can take it before bedtime and have something that's lasting a little bit longer overnight. So it sort of depends on the circumstance. But I would say that as Parkinson's disease progresses, more people rely on the immediate release levodopa because of its more reliable sort of absorption and onset of action.
Excellent. And we have a question from our social channels from Karen C. Are there any meds that can be used for extreme fatigue that she experiences?
So fatigue is a really challenging symptom to treat in Parkinson's disease. It's one of the most common non-motor symptoms, and one that I didn't list here with a specific treatment because it's often multifactorial. So we want to be sure that you're sleeping well at night, eating well, that your motor symptoms are addressed. Some people can get really fatigued when they're having wearing off. So sometimes adjusting and treating the wearing off can improve fatigue. However, there are cases where fatigue really is an independent symptom from all of those. You're sleeping well, your motor symptoms are otherwise well controlled, and you just have extreme fatigue. In those cases, we can sometimes use medications like stimulants, medications to sort of boost your energy, boost your sort of attention to help with that fatigue. And that would include things like Ritalin, for example. So those medications, of course, have their own set of side effects too. So it's important to talk about those with your doctor. And then, as I mentioned at the very beginning, exercise can also improve energy levels and fatigue in Parkinson's by stimulating sort of natural endorphins. So being sure to sort of use exercise to your advantage to help with that symptom is important as well.
Excellent. I have a question from Judy M. from their chat. Our movement disorder specialist recommended that my husband take Exelon for PD-related memory problems, starting with 1.5 milligrams twice a day and gradually increasing to 4.5 milligrams, but we are afraid of those side effects. Do you have any insights?
Yeah, so Exelon is the rivastigmine patch. So rivastigmine is a medication in the class of cholinesterase inhibitors that have the best evidence for helping with cognitive function in Parkinson's disease. So Exelon is a patch that you wear daily, and you can change it daily. So it's a once-a-day medicine that can help with those thinking problems. I will say, compared to the oral, the pill forms, the patch actually has less side effects because GI upset, stomach upset is the most common side effect of this class of medication. And so the patch avoids the stomach by having the medication absorbed through the skin instead. You can get a rash from the patch or skin irritation, so it's really important to rotate where on your body you're placing the patch each day. But otherwise, it can be very well tolerated. Sometimes it can decrease appetite, and so it's important to keep an eye on that so that you're not losing weight when you're on this medication.
Awesome. We also have a question from Sue C. What do you think of Rytary 48.75, 195 milligrams for Parkinson's stage 2?
Yeah, so so Rytary is one of those newer forms of carbidopa levodopa that is a little bit smoother in its onset and offset compared to regular Sinemet. And the dose is not 1-to-1. So 1 milligram of levodopa in your Sinemet is not equivalent to 1 milligram of levodopa in your Rytary. And that's because of the way the drug is packaged in the capsule with those beads of medication. It's not absorbed the same way. And so to calculate and find the right dose for an individual patient sort of really depends on, how much levodopa you're requiring in general. And that depends a lot on your individual metabolism and how you process the medication. So some patients need very little in order to achieve symptom benefit, and some patients need a lot more. It might have to do with the way they absorb it or digest it. It might have to do with the way their brains are processing the medication. And so the dose is really depends on you, but that's a sort of a modest dose, I would say, in the grand scheme of things for somebody with stage 2 Parkinson's.
Excellent. And we have a question from Karen C. on our chat. Any suggestions for a PD patient who also has gastroparesis? You probably know what that word is, and struggles with taking meds as they upset the stomach greatly.
Yeah. So gastroparesis basically refers to the slowed movement of food and liquid through the intestinal tract. So food, liquid, medicines can sit in the stomach for a very long time before moving on to the small intestine. And so that can predispose somebody to bloating, nausea, etc. So there are some tricks with levodopa in particular that we can use to try to help with that. One is to take actually separate from your medication extra carbidopa. So that medication that blocks the metabolism of the Sinemet in your stomach, you can take extra of that with your doses to try to help minimize the GI side effects. There's another medication called Tygan that is actually being removed from the market, but it was a sort of anti-nausea medication that was helpful, that does not impact the way your dopamine works. There's another medication in that class called domperidone. We actually don't have that medication available in the United States, but it's easy to obtain from Canada. And then the last medication that we might consider would be one called ondansetron or Zofran, which is another anti-nausea medicine that again does not interfere with the dopamine.
Okay, we're going to take, since we have a lot of great questions on the chat functionality, but I want to task it out to the audience for at least one verbal question to be asked. So if you do have a question that you can ask verbally, please unmute yourself, say your first name and ask your question, because we have about 5 minutes left with the doctor. Any questions from the audience?
Yes, Michael Umansky and Sherry, the wife. And Michael's biggest problems, well, he has a number of them, but he really, his sleeping is very disrupted. And what's safe for him? We've tried melatonin. It really is not effective for him. And with the good sleep hygiene, etc., are there any medications that you can recommend from medical marijuana, which isn't legal, to other things that are, more tried and true?
Yeah, so I mentioned sort of the lack of data on medical marijuana. I'll start there since you asked about it. I will say in my anecdotal experience, so patients who have tried it have told me that the symptoms it helps most with for them are anxiety and sleep. So my take is that if you are going to try it, try to get pure CBD as best you can, and maybe it will help, but I really don't know. I can't tell you for sure. There's no study that would prove that. There are, however, several other medications when over-the-counter melatonin is not sufficient that can help with sleep. So part of that might involve talking about what is disrupting your sleep. Is it trouble falling asleep, insomnia at the beginning of the night? Is it waking up very frequently? If you're waking up, are you waking up because you have to pee or because you're having cramping or stiffness that's bothersome? Or are you simply waking up and not feeling tired at night? So trying to pin down what the specific reasons are can help guide the specific treatment. If insomnia or just trouble sleeping, getting to sleep and staying to sleep is the main problem, There are medications we can use, including things like trazodone or mirtazapine, which are prescription medications that are non-habit forming for sleep, to other sort of what are called sort of non-benzodiazepine sleep medicines. These include things like Lunesta, Ambien, etc. I would say if you have a lot of dream enactment behavior at night, if you're acting out your dreams and that's awakening you a lot of vivid nightmares and, you know, yelling, kicking, punching in your sleep, that's waking you up a lot. And if melatonin is not sufficient, then the next medication we would use would be a benzodiazepine called clonazepam for that problem. So I think, talking through these options with your doctor and trying to hone in on what exactly is disrupting the sleep can be helpful to tailor the treatment to you.
Awesome, thank you. That's all the time we have for Q&A today, and I'd like to thank Dr. Keener for joining us. It was very informational. We had so many great questions, and hopefully the next time we have something like this, we can ask all the questions. So thank you so much for joining us today. We'd also like to thank our sponsors, Boston Scientific, US World Meds, Abbott, and Linda and Stuart Resnick. I'm Laura Kurtenbach. I'm a board member of Parkinson's Community Los Angeles. I forgot to introduce myself at the beginning. And I want to thank all of you for joining us today for our Let's Talk Parkinson's series. And I would like you guys to keep your eyes peeled. If you're not on an email list, go to the website and sign up. We will be sending out an update to our email group and posting on social of all of our upcoming events. So definitely check those out. And once again, Dr. Keener, thank you so much for joining us today. With that, I just want to invite for any of those of you who want to stay online after we let Dr. Keener depart and want to meet some of the community and talk and have like a mini support group and meet some of us face to face, because sometimes it's hard with such like a big area like Los Angeles. One of our board members, Judy Yaris, will be hosting an impromptu support group. So you guys can meet face to face via Zoom to really connect that way, considering we're all kind of safe at home right now. So thank you so much, Dr. Keener, again.
Yeah, thank you for having me, and sorry I couldn't get to everyone's questions, but enjoy each other's company on Zoom, and it's great to see so many familiar and new faces here today. So stay well, everyone.
Thank you.